All right, thank you. I'm from UC Irvine, and I'm going to talk about our experience with the Align RT system when it comes to the TrueBeam STX platform and the 6D couch and how it's complemented and how we've actually been able to implement it into our facility. So just a quick disclaimer, I'm not employed or affiliated with Vision RT, but they did provide the airfare and the hotel stay for this particular meeting. Of course, we'll be discussing the clinical workflow that's done at UCI, but it's also recommended that each department develop their own that best suit their own clinical needs. With that being said, I'm going to give you a little overview of our department and our equipment and talk about how we used to perform SRS cases and what the standard of treatment is now in our facilities. We have 4 oncologists, 4 medical physicists, 2 dosimetrists, 8 therapists, and 2 nurses that are fully staffed at all time. As far as equipment goes, we actually have 2 linear accelerators. We have a Variant Trilogy with the Align RT system, the Variant TrueBeam STX that comes equipped with the Calypso, the Align RT system, and the 6D Perfect Pitch Couch. We also have a brachytherapy suite where we have a VeriSource IX afterloader with the Acuity simulation system. And as for CT simulation, we do a Philips Brilliance Big Bore CT that comes with the Variant RPM and the Vision RT Gate CT as well. So here's a couple of photos of some of the suites in our department. That's our HDR suite, our Trilogy suite. And one of the neat things about our CT simulation room is it has the ambiance, which is one of the nice things that patients actually enjoy when they come to our department. They're able to select a particular theme, and the rooms in the actual, and the lights in the room actually change. It plays a little cinematic video. So when they're getting the simulation, it feels like they're actually in the ocean swimming with fishes, or they could have a little scenic route like they're in Tahiti or so. So it's one of the nice things in our department that one of the patients really do enjoy. And it's really nice when they come for the first day because they're really apprehensive about the whole radiation process, so that kind of puts them at ease. So I want to talk about SRS cases in the past. And at UCI, we actually did perform these procedures with the Variant Trilogy. We had a program from 2008 to 2014, but unfortunately, between the span of 6 years, we only treated 7 SRS cases. 2 of those were actually cone-based, and the other 5 were using the ZMed Variant optical guidance systems. As some of the previous speakers had mentioned before, we had some issues integrating that system into our department. Patients will complain about the bite block, as far as the extensive and all the labor that was required to fabricate all these devices. So when it came time to treatment delivery, it wasn't as smooth as the physicians would like. So what actually happened in our department, every time we got a referral for a patient that could have been a candidate for SRS, they were actually referred out to a local facility for Gamma Knife, simply because the physicians and our department as a whole was not satisfied with how the system was working for us. So we never really performed that many stereotactic cases. But that all changed in 2013, where we actually were able to acquire the TrueBeam STX with the 6D couch. So of course, this is some of the pictures of with the ZMed system. As you can imagine, all the time that actually took to fabricate all these devices, and then you're asking the patient to hold that bite block for about an hour or so, then you put a mask on top of that. They would complain, and if you ever had a bite block inside you for a amount of time on top of it, coupled with the mask, it's kind of tough to breathe. It's tough to me to breathe when I have a mouthpiece and a broken nose bleeding, but I can only imagine how these patients feel. So when we wanted to reignite our SRS program, we wanted to find something that would be much more user-friendly, and most importantly, something that allow the patient to be very compliant when it comes to the treatment delivery. So as I mentioned, in 2013, we acquired the Variant TrueBeam STX. It replaced the Variant 2300 that actually had photon blocks. So up until that point, we were creating blocks for these patients. So we wanted to reignite our SRS program. We wanted to take advantage of the HD MLCs and the FFF mode when it came to the TrueBeam STX. In addition to that, because of the previous experiences we've had with the ZMed system, we wanted to we had rotational issues, and we wanted to complement that by actually purchasing the 6D couch, so we could not only get the patient in an accurate position. In addition to that, we also wanted something to help us with the intrafraction and interfraction monitoring, and this is why we went to Vision RT as opposed to different vendors, because of the simplicity. To a certain extent, it's just very simple to use and doesn't require a lot of fabrication for these devices, and ultimately it's going to be much more comfortable for the patient, and they're going to be much more compliant come for the treatment delivery. So this is our TrueBeam suite. As you can see, we have the Calypso and then the 3 camera pods for the Vision RT. And that is, we do have the Calypso tabletop at all times, and you can see the accordion on the 6D couch. So if I'll play this video of the 6D couch if you guys haven't seen it in motion. So this is, we're actually adjusting for the pitch and roll in this particular video. Could you play this? It's a little bit of lag, sorry about that. But you can imagine sometimes with the rotational issues we had, if we're able to correct it with the accordion after the shift is applied, you can see that it's kind of tilting toward one side. And if this, for example, if the patient needs to bring their chin down, we could actually elevate the table so as you can see it's kind of skewing down. So that allows us to be accurate in 6 different motions, not only the transitional but the rotational as well. But we wanted something to complement that as well. So that's why we chose the Align RT system. Because of course it's going to give us 6 different readings at real time. So now if you're able to mechanically adjust the patient position using the couch, it's very useful, but now we have the surface guided system, we actually know where exactly we would need to move the couch in that, so it complements it really well. And on top of that, the versatility that the system provides for us was also a big point for us choosing this particular product over the competitors. Now in our facility, we actually use it, we standardize it for most IMRT brain treatments, head and neck treatments. We do deep inspiration breath hold, SBRT treatments, and some extremities as well. But of course, implementing a software is always going to be a little bit difficult, especially when it comes to the status quo, especially when you have staff that's been in the field for about 20, 25 years. So the biggest obstacle when it came to the Align RT was actually understanding the concept of the system. For the longest, the thought is the more you immobilize the patient, the more you're able to restrict their movement. But now you're telling, the staff that actually you don't need as much immobilization, you just need more surface. So in hindsight, the staff thinks about, okay, so you're telling me to remove all of this, what I've kind of known in the past, and patient will be more prone to movement, but then you're counting on the system to actually detect that. So that was very difficult for us to understand, but as the clinical practice and we started doing more cases, we became much more comfortable in the system, and now it's fully integrated. We had so much success with the system, we actually purchased it for the Variant Trilogy. For the Variant Trilogy, we don't have the 6D couch, but we actually use the compatible Align RT tabletop where we actually adjust the pitch and roll like Matt showed you previously. On top of that, we also have to figure out, it was a trial and error in regards to what are the optical treatment devices and how are we going to patient these positions so we can partially immobilize them so they can lie in the exact same position, but also provide the cameras with enough surface that they need so they can actually perform that function and we can get accurate data that we could use when we're setting up these patients and ultimately delivering the treatment. Our biggest breakthrough came in September in 2014. We actually went live with the TrueBeam in April of 2014. That's when we actually performed our first SRS case with the Align RT system. So as I mentioned before, we actually purchased it after a couple of months for our trilogy, and we use the tabletop that's compatible so all our IMRT brain patients. So we also able to offer the patients the Align RT system on any of our linear accelerators so they kind of don't feel that it's left out because we actually advertise it a lot through social media. But ultimately, the reason why we did get the Align RT system was for our SRS procedures. So as I mentioned before, between 2008 and 2014, we only performed about 7 procedures. In the span of 18 months, we performed 45 SRS cases, and that number jumps up to 65 if you include SRT cases as well. It's very popular among physicians now. All our practicing physicians have participated in the SRS procedures, and some of the neurosurgeons in our department that were actually fixated on the thought of the gamma knife. After a couple experiences of their patients as they've gone through us for the SRS cases, they become a little bit more lenient, and they have grown on the actual Linac-based frameless treatment. So that's why we're actually seeing our numbers increase. In addition to that, we actually made a social media campaign. UCI has a big anti-cancer ad, and we actually released a viral video where we actually document the case of a patient that actually comes to our department for an SRS case. So we highlight our TrueBeam, our 6D couch, and the Align RT system. So it actually, it was able to spread the word to the community that we have these capabilities, and we actually have patients that come about 3 to 4 hours from Apple Valley, from Orange County, just to come receive their treatment, just because they become aware of what we're able to do here. So with that being said, I just want to talk about what the clinical workflow is for the SRS cases from the time of consultation to the time of treatment delivery. So once they come for consultation and the physician sees that they are a suitable candidate for frameless based, they're going to go ahead and submit the authorization. So we can get started with the planning process and the simulation process. Once for simulation, they usually have a dynamic document that they fill out. In this particular case, This patient was actually receiving SBRT to the lumbar spine and an SRS to the intracranial SRS. So they'll indicate it there that they want the Align RT system with the SRS, and they're going to want the images to be co-registered with the planning MRI. It's kind of become our protocol to have the patient have a planning MRI and a planning CT at the same time when they're coming to our department. So once we get the authorization back, we actually will coordinate with the radiology department and we'll schedule an MRI and the CT on the same day. We usually do it within the same time frame. And this is in order to facilitate the patient and reduce the patient wait times that they have to wait between these procedures. So typically we'll instruct them to go to MRI and then we'll actually go over there and bring them over to our department. So that way too we could streamline this process because typically they spend the most of the time in MRI and we don't want them have come back for multiple appointments so we can get all of this done in one day. So once they come to our department, what happens is we actually instruct the patients to change into a gown, especially if they're wearing bulky clothing, because sometimes they're wearing sweaters or crew neck sweaters that actually might affect the pitch and the roll when it comes to fabricating the immobilization devices. And as some of the other facilities, we actually have two simulation radiation therapists that participate in this procedure. That's because we found that it's very critical at this moment when you're making the mask to make an optical mask, a mask that's going to be optimal for to immobilize the patient and also have enough surface when it comes time to the treatment delivery. You're able to draw a ROI that at all time is going to be useful, especially since our particular treatments, we have about anywhere between 4 to 9 couch rotations. And so what happens, and we do use VMAT, at one point in time, some of the cameras may be obstructed, but if you're able to fabricate a good mask, what camera might be lacking, you can make up with enough surface on the opposing side. So that's one of the big obstacles we actually had to learn as we started performing more of these procedures. As far as mobilization goes, we use an Accuform headrest, and we use a thermoplastic mask that's compatible with the Align RT system. So this is what it looks like. It's similar to what the one other facilities use. The nice one about where this Accuform headrest lays, it kind of has a little donut. So what happens, we mold that the Accuform to kind of fill into that little donut. So what happens, it doesn't slide, so it kind of avoids there to be any roll or any pitch when it comes time to putting on the mask. As far as the mask goes, it's an open mask, but we actually reinforce the chin. It has an elongated strap, but we actually fold it back up to reinforce the chin because one of the biggest issues we had initially was the pitch. So we actually able to reinforce that at the time where we're making the mask. It's able to help us position them really well and also get adequate surface when it comes time to the treatment delivery. So I said usually one of the therapists is going to apply mild pressure on the chin and on the forehead while the other therapist is going to focus on the lateral aspects of the mask. We usually try to extend the mask to cover just anterior to the ears so we can get enough surface on the sides. So when it comes time to the treatment delivery and we do have those rotations, we have enough surface on each side so we can continuously, should I go back? Oh, sorry about that. They're kind of both not in sync. Yeah, right, that's fine. Okay. So usually we'll stay with the patient until the mask is fully dry. We'll apply a wet cloth and we make sure everything is dry before we actually do our scan. We use a sagittal laser to make sure that there is no roll. And then we'll go ahead and scan. And we have our own particular scanning protocol when it comes to these patients. We actually scan in 1 millimeter slices, and then sometimes we actually do 0.8 depending on the discretion of the physician. And we usually scan the entire head to the top of the shoulders. That's just because we do have a lot of couch rotations come treatment planning. So we want to make sure that we're actually going to be able to clear that particular area for our treatment delivery. So once we do the scan, as you can see, these are the orthogonals, the scalp films, and this was actually done at 0.8 millimeters. And then we'll document everything. We'll take an anterior and lateral photograph of the patient's mask. So that way, when it comes time to the treatment preparation, when we draw the ROI, we could reference back to that particular scan, to the images, and actually draw an ROI that's much more accurate and going to give us enough information for the treatment delivery. So as far as treatment planning goes, the images are sent over to be co-registered by the medical physicist. Usually the physician will go ahead and contour on the MRI. And before any of the planning is sent over to the Eclipse, usually it's reviewed by the neurosurgeon. So once both of them are in agreement, we're going to go ahead and start the treatment planning process. Most of our plans are just single isocentric. We've treated just a single lesion to the most lesions we treated in one particular case was actually 19, which was pretty, a little bit out of the normal, but typically it's about 2 to 4 lesions, but we actually have treated up to 19 lesions before. Our PTVs usually include a margin of 1.5 to 2 millimeters, depending on the preference of the physicians. And once everything is approved, we're going to go ahead and all the quality assurance is done. We're going to actually proceed to the next step, which is the treatment preparation. So this is some of the planning. As you can see, I believe this was 3 different targets. This is just one of the particular targets, and everything's co-registered to allow for simple contouring of the targets. Now, the treatment preparation is actually what where the therapist kind of takes over and imports the plan that was actually attached to the prescription in ARIA. So we make sure we do a lot of cross checks. We make sure that we import the appropriate the plan that's correlated to the prescription, and we're also going to check that we import all the rotations as well. Once we do that, we enter them to the registry, and we're going to go ahead and select our actual default settings for our ROI. The nice thing about the Align RT system is because it comes with predetermined anatomical sites that we could use. So we use the intracranial, and we'll actually adjust those settings come time for the treatment delivery. So as you can see, we've pulled in the plan with the DICOM ISO center, and then we've double-checked that all the couch rotations were actually imported successfully. And then we're going to go ahead and proceed to draw the ROI. So as you mentioned, we did take the lateral and anterior photograph. So that's what was taken at the time of simulation, and this is what we actually drew out for our treatment delivery. So it's kind of nice for us to have it side by side so we could actually visually see where exactly the mass is extending to. So it's one of the biggest tools that actually help us draw a consistent ROI, because initially what we were doing, we were actually overshooting and we were actually monitoring some of the mask. So now this little process has kind of helped us out tremendously. So now we proceed to the next step, which is the treatment delivery. For our first initial cases, we actually would allocate about an hour and a half for these SRS procedures. That's because we were not really familiar on how the system was really going to work for us. We were not too confident with the Align RT system at that time. So what happens, we would actually CBCT almost after every partial arc. So we would include about 4 to 5 CBCT, so that because we weren't really sure if the deltas that we were seeing in real time were actually true values. But as the time went on and our practice kind of grew and our experience grew, we're actually doing fewer CBCTs. We typically do 2 to 3 per treatment, and we actually allocate only a 45-minute time slot. We're actually usually done in about 35 minutes, but we usually allocate an extra 10 minutes just for some unforeseen situations arise. We also have the presence of the medical physicist, the radiation oncologist, and some occasions the neurosurgeon. Typically, the neurosurgeon that was typically fixated on the gamma knife would always be present when we first started these procedures. But now it comes to the case that actually they rarely come by to our department. They only come by to check the contouring, but that's because they've kind of grown very fond of the system and they've trusted some of their confidence in them, which is one of the nice things that let us know that we're actually doing the right thing and that the system is working out for us. So once they come for treatment delivery, we actually have them changed into a gown. And one of the big things we do, we actually show them a tour of the console. So that way they have a better understanding of what exactly is going to be going on. We actually have them spin the actual ROI that we actually draw on them, which they actually find pretty interesting. So they kind of see, okay, this is what they're going to be monitoring at all the time. So I have to be aware that I cannot be moving. So that's one of the things that actually helps us when it comes to the treatment delivery, because sometimes patients are just brought in and laid on the table and the lights start flashing on them. So we actually take the extra step to kind of explain everything to the biggest detail. And then that way, when it comes time to setting them up, they're very compliant. And what that means is going to be that the treatment is going to be done fairly quickly. We lay out all the demobilization devices. We don't index our S-frame overlay. Some people ask, why is that? It's because sometimes the location of the ISO center, we could actually just manipulate the overlay to either move in one direction. And then if we have to fix the yaw, sometimes we could just manipulate the S-frame with actually spinning it. So like I said, initially we would do 4 to 5 CBCTs, but now in our current practice, we're doing about 2 to 3. That's because we found particular methods to verify that the delta we captured after, the deltas we captured after our reference are actually still true. And then through the imaging process, kind of given us the confidence that we don't have to perform that many CBCTs between these arcs, especially since we have so many rotations at the time of delivery. So of course, this is what we show the patient, and we kind of lay out the tables, we lay out all the devices so they know what we're going to be doing. And we'll actually start laying them and start positioning them. We don't have a reference isocenter from the time of CT, so we just look at where the approximate where the isocenter is at, looking at the Align RT system because it gives us the internal point. And once we're there, we actually start monitoring the patient. We usually use a pendant just to adjust the couch with the vert, longe, and lat. Of course, the pitch roll is all done by manipulating the patient, and the yaw, we actually manipulate the S-frame overlay. And we try to get all our deltas within 0.2 millimeters before we actually start our CBCT. The nice thing we've done to actually facilitate and expedite our treatments is once we get pretty close, what we'll do, we'll actually rotate to the grossest couch rotation for our treatment delivery, and then we're actually able to check the clearance beforehand. That's because once we do our imaging and actually review our shifts, they're such minor shifts that they're not going to actually raise a flag when it comes to a potential collision come the time of treatment delivery, which is nice because once we step out of the room, everything we're doing from that moment on is just related to the actual treatment delivery for the patient. We don't take orthogonals, we actually go straight to the CBCT because typically the location of the isocenter is located where exactly the ROI is, in a fairly good position. We kind of felt it's an unnecessary step unless the location of the isocenter might be very inferior. For example, if it's something near the brainstem, then we'll actually take KV orthogonals to account for that, but typically we'll just go straight to a CBCT, which we actually reconstruct at a 1 millimeter slice thickness at a 512 matrix when we actually perform that. So what we'll do, we'll step out, we'll do the CBCT, and we actually relax the imaging tolerances to 2 millimeters because what happens is, of course, as the gantry is rotating, some of the arms become obstructed at certain periods. But we've seen that typically the deltas don't really fluctuate that much, but it's just kind of as a safeguard for us to do that. So this is a video of the CBCT being performed. So as you can see, we still are monitoring at all times, but we are relaxing the tolerances. I promise it was much more smoother. We don't take that long. Unfortunately, it looks like it's not really working to its potential, but we actually focus on the screen where you can see that we're actually monitoring the patient and doing the CBCT at the same time. So once we do the CBCT, what we'll do, we'll retract the imaging arms and we'll continue monitoring the patient to make sure that they're not moving while we're actually co-registering the CBCT with the planning CT. We'll take an initial look on how the positioning is, and then we'll run the auto match using the bony anatomy. And then we'll turn on the contours that the physician decides to turn on, and we'll evaluate the CBCT. One of the nice things that we've noticed as we perform more and more procedures is that the shifts that the actual TrueBeam is suggesting versus the real-time deltas are very close to an agreement, which is nice because it gives us confidence what we're actually seeing on one system. So they're kind of both talking to each other. So since they're both in agreement, it gives us that confidence that we are getting the patient in the right position. And like I said, we just do straight to the CBCT because we do have the 60 couch, and typically the rotational errors for the pitch or the pitch or roll are so minor that we could easily correct for it when we do the CBCT. So this is the initial CBCT that was done. This is as soon as we set up the patient. You can see our biggest shift was just 1.2 millimeters, but this is just from the initial setup. So once we capture it, so I try to window back and forth so you can see there's almost little to no movement. Of course, a 1.2 millimeter shift from your initial setup is pretty good for us, but we see once we repeat the CBCTs, that number is much more dramatically a decrease because we're able to monitor them with 1 millimeter tolerance. So that's our initial. So once we do that, we're actually going to capture a reference. So we'll apply those shifts, and then we'll capture a reference, and then we'll change all the tolerances to 1 millimeter and to 1 degree for rotational errors. And then we'll gate the beam. The nice thing from that point on is kind of cruise control when it comes to the treatment delivery. The Align RT system does allow for a time delay for as far as the gating goes, but we don't allow for that. you could actually typically allocate a second or two for the beam to actually stop, but we actually allow for no time delay. So as soon as the patient goes out of tolerance, immediately the beam stops. And typically and the nice thing about that is that we don't have to use our human reflexes, because you could use your judgment, but you can only be as fast as you just naturally are, because unless you play that little groundhog game a lot, then you have to anticipate when the patients are going to be moving out of tolerance, and we never know when that's going to happen. So it's kind of a safeguard, and it kind of puts everything in cruise control when it comes to the treatment delivery. So I attempted to put a video. So you guess when the patient's going to go out of tolerance. So everything's at 1 millimeter. It's being delivered. When is it going to go? So this is the nice thing, that we don't have to do the manual. So there it went. So this is a fraction of a second. So the nice interface between the Align RT and the TrueBeam allows for that to happen. Typically, we'll see sometimes the patient might move a little bit, or if we have any doubts of whether maybe it might be the camera that's being obstructed, what we'll do, we'll actually pause the beam, and we actually will rotate the gantry away and give it a couple of seconds to see whether it's actually in, if it goes back to within tolerance. And if that's the case, what we'll actually do, we might relax that tolerance to maybe 1.2 millimeters just to clear that, but we typically don't have to allow for that. But if it stays out of tolerance for a significant amount of time, then we'll actually go ahead and do the re-imaging. So typically the first arc is at 0, and then we'll rotate to maybe possibly a 45 or a 60-degree couch kick. So what we do, we actually go ahead and go to the TrueBeam parameter that's indicated, and then we'll select the ROI that with the appropriate couch rotation, and we'll see where that lies. The nice thing about that is, since we have enough surface, because the way we fabricated our mask, we're able to get consistent readings, and then since we already checked the clearance, we know that we could just proceed to the treatment delivery. So what we'll do, we'll actually treat that arc, and once we're done, the nice thing about the TrueBeam, you're actually able to rotate back to where you captured your reference 0 at from the outside, and then we'll go back and change to our reference at our 0, and if all the deltas are still within agreement, we'll proceed to treat the following couch kick, and then we'll go ahead and do that once again. So once that's done, we'll rotate back to the outside to our 0, check our Align T system, and if the patient's still within 0.01 millimeters or 0.02, we'll proceed to the treatment delivery. At first, we had issues whether we should trust the Align RT system, because we were doing multiple CBCTs, but of course the imaging and the shifts were so minuscule that I felt that confidence that we could just treat one side, and we'll go back to our 0, and then we'll do a CBCT in the middle to evaluate the patient positioning before we proceed to the contralateral couch kicks. So this is the treatment delivery at I believe a 30-degree couch kick. It was a little bit smoother, I'm sorry about that. So what happens once this arc finishes, we select the CBCT, and then the couch rotation will want to go back to its 0. So we'll just select it, and we'll just move the couch back to 0 from the outside, and then we'll select the Align RT to our reference 0. If everything's in agreement, we'll just go ahead and proceed and continue treating. So that's one of the ways we've actually been able to expedite the treatment time for these patients. But usually we'll do a CBC in the middle, like I mentioned, before we treat the contralateral side, and we'll proceed with the same steps. And then once we're done with the actual treatment delivery, we're going to actually do a final CBCT to see whether the patient did move throughout their treatment. But once again, that's also, when we do evaluate the CBCT, is also subject to the human eye, of course, because sometimes it looks like there's absolutely no movement. But just in order to be more consistent, we always run the auto match just to see what the system is telling us, and we'll compare that to our real-time deltas. We'll see a little bit difference once we run the auto match a second time after we capture the reference, but just as consistent practice, we always run the auto match, and if we need to shift, we'll go ahead and do so and capture a reference. So this is the final CBCT. The most grossest shift was, of course, 0.05 millimeters. So when we scroll back and forth through the different windows, you can see there's little to no motion. Well, I usually have a coronal and a coronal view as well, but unfortunately I'm not able to pull that up for some reason. But all our shifts are still within our tolerances that the physicians allowed. So now with that being said, we kind of grown more comfortable with these particular treatments. Like I said, we usually We allocate 45 minutes, but in 30 to 35 minutes, we're able to deliver these treatments. The fact that we have a 60 couch kind of eliminates the need to have a system that's going to require extensive devices like the previous ZMed system. The most important thing is at the end of the day, most of these patients are comfortable when it comes to treatment delivery. They're more compliant once you have less immobilization on them. Once you have a simple headrest and a good mass and a comfortable pad, these patients will not move throughout their treatment. So what that's indicating to us that we're able to deliver the SRS treatments that we once wished we could deliver, but now we're doing quickly and efficiently with the AlignerT system. And like I said, just the popularity it's had in our particular practice shows dividends that the system is paying off for us. And to actually have some of the neurosurgeons come refer the patients to us for the treatment delivery when they usually always go to Gamma Knife, it's a very rewarding because it shows that we're doing the right things. So that's some of our final thoughts. And then it's nice to see that our real-time deltas are in agreement with what TrueBeam is saying us, because even though they're both independent, they're both really close to one another. And of course, the interface, as far as the gating goes, it kind of puts everything in cruise control and makes sure that we're treating them within the tolerance that the physician allows. With that being said, that's my presentation. Any questions?
What parameters do you use for your auto match on the cone beam? Do you define a region of interest, or do you use like structure volumes to
So
match?
we use actually a region of interest that's particularly close to the targets, and then we'll run the bony anatomy. We'll do the auto match. We'll use the bones for the last step, and that's what we'll use for evaluating our CBCTs. And we do that consistently for the second and third CBCT. So once the ROI is defined, we'll keep that so we can have it consistent for all the CBCTs that we do, so we don't adjust it after we do it the first time.
Hi, do you ever think that you'll get to a point where you'll drop your middle and post cone beams?
I'm sorry, can you repeat that one more time?
Do you think you'll ever get to a point where you'll drop your middle CBCT and your post CBCT?
I don't think we will, because the amount of rotations that we have for our treatment delivery, some of the cases where we only have about 4 couch kicks, might skip that middle CBCT, but typically like anywhere between 6 and up, we're actually gonna. It's just a way to verify. And like I said, sometimes when we actually do the CBCT and we evaluate it without doing the auto match, it's actually very spot on. But like the physicians like to be consistent, because they ran the auto match the first time, they're going to run it the second time. So it's just a matter of being consistent. And of course, just for documentation that we actually are performing these CBCTs when we have extensive arcs and couch kicks. Anybody else saw the question right here?
What's your typical variance on your post-CBCTs? That's interesting because not a lot of us are doing that.
Mm-hmm.
Is it about 0.5 millimeter, would you say?
Yeah, so the final this is the post-CBCT. This is done at the end. So as you can see, the biggest fluctuation was in the longitudinal, which was 0.05 millimeters. So the physicians allow for that 2 millimeter margin, so they feel comfortable with that as well. So like I said, and once we were able to kind of win the neurosurgeons over and all our physicians, and then we've been confident that we don't require as much imaging as before, because we're able to fabricate a good ROI at a time for the treatment delivery, so we're getting consistent deltas. But then again, like I mentioned before, this is all just based on the auto match. Sometimes you have to evaluate yourself whether the auto match is true or the actual CBCT that you actually get without any shifts is spot on. So it's just interpreting it as far as the human eye goes.
Hi. You were talking about like sometimes if the real-time delta is more than 1.2 millimeter.
Yes.
You said you would adjust, you would modify the tolerance instead of taking another cone beam. Can you talk a bit more about that?
So usually what happens if it just happens at a single point, like we'll stop the beam, we'll actually move the gantry out of the way, and then we'll rotate it to the particular sequence, and if it stops again at that particular point where we did become out of tolerance, then we know that it's just limited to that area. So what we'll do, we'll just increase it for that beam, and then once we proceed to the next arc, we're actually change back to our 1 millimeter tolerance. But of course, if it's fluctuating as we're moving away, the gantry away from it, then we're going to go ahead and do another CBCT. Okay, all right, thank you.